Welcome to the Social Determinants of Health legal series. This is going to be the second installment of the series. Last month, we went over social determinants of health and legal and healthcare, and this month we'll be reviewing HIV criminalization. I know the invitation said the STI, but I don't think there's going to be much information on STI this month. That was the intention when I initially set this up. But thank you all for joining us anyway. All right, so for today's objective, we're going to do welcomes and introductions. We have a poll and trivia questions that we'll complete on Metameter. It's a new site that Dori recommended to me. And then Dori will be going over the history, the impact, and modernization of HIV criminalization laws. She's one of our senior managers at NASTAD. And then also we have Adrian from the New York City Department of Health and Hygiene doing select HIV criminalization efforts at New York City Health Department. And then finally, we'll have room for a Q&A session. All right, so welcome, everyone. My name is Rodderick Sheppard. My pronouns are he, him, his. I am a manager on the prevention team. And what we have right here is the Social Determinants of Health team. So should you have any questions regarding the program, but the Social Determinant of Health programming at NASTAD, please feel free to contact us. And just so you know, at the end of this webinar, we will be sending out the recordings and also the slides, so you'll have access to our information. And also, we always like to give thanks to our CDC partner, Maria E. Alvarez. I don't know if she's in the house tonight, but thank you, Maria. Feel free to unmute your device if you want to say some words to the people today. I don't think Maria is with us. Thanks, Maria. All right, so now we're gonna go on to the poll and the trivia. So you can go to www.menta.com and enter the code on the screen to join the trivia and the poll questions. I'll just give people a second to join. And I want to go ahead and pull up the website. Give everyone a second to log into the website. We're going to put in the URL and as well as and I don't know if y'all can hear me, open the music. So let's get started. As of 2022, how many states criminalized HIV exposure? Get those answers in. On Nobody got that right. It's a total of 35 states, according to the CDC, of how many states criminalize HIV exposure. Okay, I was just told it's a little loud. I hope, is that a little better? I'm sorry, everybody. Okay. All right, next question. What year was the first HIV Pacific criminal laws enacted? All right, we got 5 people that got the answer right. It was the first laws were enacted in 1986. All right, we got Maddie in the lead, Macy in second place, and Alexis in third place. All right, y'all, let's see who's going to take it home. We got one more question. Select a state that did not enact HIV Pacific criminal laws in 1986. There were 3 of them. All right, so Texas was one of the states that did not enact HIV criminal laws in 1986. Their first 3 were Washington, Florida, and Tennessee. All right, and we have Maddie for first place. All right, it looks like some people already started responding to some of the other questions outside of the trivia portion, but right here is, we wanted to solicit some feedback from you all. We wanted to know, what would you like to know about HIV and STI criminalization? You can respond more than once if you want to. And then hopefully we might go over some of these items, and if there's anything that we missed as a part of the Social Determinants of Health series, I'm certain that we'll definitely revisit this topic and make sure to review this in future reference. So far we have, what can we do to change the laws? What progress has been made to overturn HIV/STI criminalization laws? How can my jurisdiction advocate for the appeal of HIV/STI criminalization laws at the local and state level? What does advocacy look like? These are some great questions, y'all. How to overcome barriers by leveraging EHE coalitions. And I'll give people maybe 1 more minute to respond. I love that people went ahead and answered the questions. That's pretty dope. All right, so it looks like that might be all of the responses. I'm going to go ahead and move forward to the next question for the sake of time. Okay, so we would like to hear from you. How is HIV/STI criminalization a barrier to the work that you do? And this will kind of help us, and this will help inform us on maybe some different ways that we need to do some research to come up with some solutions for the barriers that you might face. Causes distrust and fear of the system. Yes, it does. prevents implementation of best practices. Any other responses out there? Discourages HIV testing. Okay, so HOC is not wanting inmates to receive PrEP, saying there is no sex activity going on in prison, so inmates infect each other. That's a really, really good point. Creates stigma. There's a barrier to follow up with individuals previously diagnosed with HIV. Absolutely. All right. Makes retention difficult, no way to track inmate. I wonder, is there more to that? Or is just no way to track inmate? Oh, no ways to track inmate after release. There we go. We're supposed to move. Okay, so it encourages myths about how HIV is transmitted. All right. Well, thank you for your responses, everyone. We'll definitely keep this in mind in future presentations about HIV and STI criminalization. So what I'm going to do now is I'm going to stop sharing my screen and allow Dori to take over so she can give the overview of HIV and STI criminalization. All you, Dori.
Thanks, Rodderick. I'm just going to share my screen. Okay, so everyone see what they're supposed to see. Yes, looks good. Everyone sees my slide. Okay, great. All right, everyone, thanks for joining us today. Today's session is about HIV criminalization. And so we're going to start today with a conversation about the history of HIV criminalization and how it impacts public health, how states have been reforming their laws in recent years. And we'll talk a little bit about advocacy and engagement that's been happening on the ground around these issues. Although, as Rodderick said, we're hoping today to learn more from you all about like what needs you have in terms of that portion of the content and how we can better support you in that advocacy and engagement. But I will touch on it a little bit today. First, let's start with what is HIV criminalization. HIV criminalization is the prosecution and imprisonment of people living with HIV for things that are otherwise lawful, like consensual sex, or minor crimes like fighting, but are treated like more serious crimes if someone is living with HIV. It ignores medical facts about the types of conduct that can transmit HIV, the different risks associated with different types of conduct, and the role that viral suppression plays in reducing or eliminating transmission risk. It's based on outdated assumptions that HIV is a death sentence or a deadly weapon. And since the stated goal is to reduce HIV transmission, there's also an inherent assumption that the criminal system is an effective public health tool. So let's start with the history. As many of you already know, during the early years of the HIV epidemic in the 80s, there was a lot of public misunderstanding and fear about HIV. People did not understand how it was transmitted or how it could be prevented. I think everyone's probably familiar with the image of a patient quarantined in a hospital with doctors and nurses in head-to-toe protective gear. People didn't understand HIV, but they knew that young, otherwise healthy people were dying seemingly suddenly and swiftly from this new disease. Before modern treatments became available, HIV was widely considered a death sentence. Around this time, state governments began developing treatment programs and campaigns to decrease HIV transmission. In their efforts to control the epidemic, states began to pass laws that punished people who transmitted HIV to others. In 1986, Florida, Tennessee, and Washington state became the first 3 states to pass HIV-specific criminal laws. 4 years later, in 1990, the Ryan White Care Act actually required every state that received Ryan White funds to have laws that could be used to prosecute people living with HIV who knowingly exposed others. It didn't take long for HIV to become largely associated with people who were already stigmatized and denigrated in society, primarily LGBTQ people, sex workers, and people who use drugs. So on this slide, you can see some images that illustrate public attitudes about HIV in the 80s. Many critics of HIV criminalization laws would argue that the claimed motive for passing them, to fight HIV and prevent its spread, was actually just a pretext for putting so-called undesirables behind bars. These groups were already heavily criminalized, and HIV gave law enforcement and the criminal system yet another reason to police and punish them. For example, engaging in sex work is a misdemeanor and typically carries only a couple months sentence, if that. But if a sex worker was also living with HIV, the criminal system now had an excuse to charge them with a felony and keep them behind bars for a longer period of time. The existence of these laws also compounded the stigma and prejudice that led to their creation in the first place and turned these groups into easy scapegoats. HIV was their fault because they did something that society considers to be bad behavior. A good way to validate in the public's mind that certain behaviors or certain groups or certain people are bad or dangerous is to reframe those people or behaviors as being inherently criminal. As of 2022, 35 states have laws criminalizing HIV exposure. This is done in two ways. 21 of those 35 have HIV-specific criminal laws. They apply only to HIV. Even though HIV, of course, is not the only sex-related risk, and there are other diseases that transmit sexually more easily or have very serious long-term health consequences, HIV has been singled out with unreasonable laws and punishments. Of course, these diseases should not be criminalized either. I'm definitely not saying that. I'm just trying to highlight how, illogical it is to single out HIV and how, not at all based in science it is to do something like that. And 14 of those 35 states have laws that target communicable diseases more broadly, including but not limited to HIV. So we have, states with HIV-specific laws, states with communicable disease laws that almost always, if not always, include HIV. And then in addition to that, there are 4 states that have enhanced sentencing for other crimes like assault if the defendant is living with HIV. So that means that 39 states in some way single out explicitly in their laws HIV or other communicable diseases and create new crimes or harsher penalties that only apply to people living with those diseases. Whereas people without a communicable disease who engage in the exact same activities, like consensual sex without a condom, are not criminalized at all. But even if your state does not have one of these laws, every state has general criminal laws that could be used to prosecute someone. For example, reckless endangerment or attempted murder. So really, this is an issue in every jurisdiction in the US. These laws do not improve health outcomes or further public health and can actually hamper our efforts to reduce transmission in the community. The stigma and fear of legal consequences that these laws create and perpetuate deter people from accessing prevention, care, and treatment services. They also perpetuate a culture of blame around HIV infection and treat people with HIV like public threats. It's your fault you're in this situation, so it's also your job to protect other people from yourself, is what these laws are saying, which is obviously illogical. It can't be both your fault that you're living with HIV and also your fault that someone else is living with HIV. On the other hand, these laws, this is the message that they send, as opposed to sending the message that, everyone is responsible for taking precautionary measures when engaging in sex, and your own health does not necessarily depend on other people disclosing their status to you. It also breeds mistrust of the healthcare system, especially since the communities that are most at risk of HIV are also communities that have historically been excluded or marginalized by the healthcare system and providers. If you already believe that a system is designed to work against you and stigmatize you, then you very understandably don't feel comfortable disclosing any information within that system. And you may not believe that providers will give you competent care and prioritize your health and well-being if you're worried about being judged or punished for your behavior or choices, especially if you share something that might expose your participation in criminalized activities like drug use or sex work, and especially if you already have a criminal record. If exposing others to HIV is a crime, then your sexual activity also becomes a crime that you may be hesitant to disclose to an institution that you don't trust. There's also been a lot of concern in the community in recent years about surveillance and program data being misused, particularly for law enforcement purposes. This can make people reluctant to share information with providers or case managers if they then think that it could be, subject to disclosure to a prosecutor. And these laws, like most criminal laws, are applied unevenly based on race, sex, and socioeconomic status. So they also deepen the disparities that already exist in the legal system. Here's a graphic from the Transgender Law Center that illustrates how fear of HIV criminalization is a deterrent to testing and treatment, especially for people who belong to already stigmatized and criminalized groups. Even the most, quote, progressive or modernized criminalization laws, and I use air quotes because I think many people would argue that this is inherently contradictory, can still deter access to preventive services, testing, care, and treatment. An average person isn't going to say, I better disclose my status to my partners in case I'm prosecuted because disclosure is a statutory defense in my state. More likely, they're going to think, if I don't know my status, then I can't go to prison. This effect is only heightened if they use drugs or engage in sex work, for example, and already probably have a deep mistrust of the legal system and bad experiences with the legal system. To further illustrate how damaging these laws can be to our efforts to reduce HIV transmission, one study found that 7% of HIV negative men who have sex with men in the study were less likely to seek HIV testing because they're worried about criminal consequences. And that 7% reduction in testing could increase transmission in the community by as much as 18.5%, overwhelmingly driven by undiagnosed individuals not seeking care and treatment. These laws also deepen racial disparities that already exist in the legal system. Here are a couple of examples of news stories published a few years ago about HIV criminalization prosecutions. What struck me about these stories is that they both have near identical facts. Both are about Black men who received uncharacteristically long sentences for criminal transmission, and they were both released early because an appeals court found that their trials were racially charged and fundamentally unfair. These examples illustrate how HIV exposure and transmission laws are often applied unfairly and selectively based on race and sex. Unfortunately, many of those stigmas and misconceptions from the 80s persist today. Criminalization laws often do not reflect modern understanding of HIV, how it's transmitted, and how to prevent it. They fail to take into account major advances in HIV care and treatment available today. They treat HIV more like a death sentence rather than a treatable and manageable condition, assuming, of course, that a person has access to medication and care, which is not always a given. A number of states have therefore recently moved to change their HIV criminalization laws. I want to emphasize here before I get started that NASTAD does not take the position that any of these laws are good. We support evidence-based public health interventions, which these laws are not. So I'll talk about how states have reformed their laws to make prosecutions more difficult or reduce the harms caused to individuals and community, but I am not endorsing or supporting any type of HIV criminalization law. So with that, here are some common themes that we've seen in these reform efforts. These crimes often have felony penalties, which can have devastating consequences for people living with or at risk for HIV, especially if they have a history of prior offenses or they engage in criminalized conduct like sex work or drug use, and are already subject to heavy criminalization. A felony on your record has wide-reaching implications. You can lose basic civil rights like voting. It may be hard to find a job or housing, etc. If you already have a record, then committing another crime could lead to much more severe consequences. In many states, people convicted under these laws must also register as sex offenders. So, depending where you live, a person living with HIV who gets convicted under one of these laws comes out with a felony record and they're a registered sex offender. Add to that the discrimination they already experienced just because they're living with HIV, and also potentially just because they belong to an already socially marginalized group. These harsh penalties also exacerbate stigma. In the collective consciousness, if you're a felon or a sex offender, you must have done something really bad. So one common type of reform we see is downgrading these crimes from felonies to misdemeanors. Another common feature of recent legislation across the country is expanding criminalization laws to include other diseases, ostensibly in an effort to destigmatize HIV. However, there are some at-risk consequences that could come from this. First, you're criminalizing diseases that were never criminalized before, potentially. You're potentially criminalizing diseases that were never criminalized before, at least not directly. Like I said, you can prosecute people even without a criminal law specifically related to communicable diseases, like for assault or attempted murder. But this kind of change here creates a new avenue for prosecuting more people in more circumstances. It signals a public interest in prosecuting people with these diseases and creates a legal blueprint for doing that. And second, the privacy protections for information about other diseases besides HIV are often less stringent. than HIV confidentiality laws, which could make gathering evidence in support of prosecution much easier. So while people living with HIV have a lot of legal protections around how their data can be used and when it can be shared, that's often not the case for other diseases like hepatitis, for example. And we've actually seen this happen when a state includes other diseases in its statute. All of a sudden, the health department, starts getting requests from prosecutors for data about other diseases that they were never interested in before. And a lot of state laws already have really outdated language about the types of conduct they criminalize. A state might criminalize all sexual conduct, for example, without considering transmission risk or use of prophylactic measures. Some states broadly criminalize just transfer of bodily fluid, which is really broad and is often applied to things like spitting or biting. However, some states incorporate supportable scientific standards into their laws, only criminalizing conduct that poses a substantial risk of transmission. So I'm going to talk about some examples of that to illustrate how that works. So California changed its law a few years ago. The law used to criminalize sexual activity without a condom, but now applies to conduct that poses a substantial risk of transmission. We now know that there's not a substantial risk of transmission if someone's virally suppressed, and we know that not all sexual activity carries the same level of risk. But the old law did not make these distinctions. Sexual activity without a condom was criminalized, period. The law was static. It was based on an outdated understanding of HIV transmission. Tying the law to scientific standards allows for the law to be dynamic. As our understanding of transmission risk evolves, the law evolves along with it. This is especially important given that it's not easy to reopen a law and update it later. It's a long process, and there's political considerations, and there are a lot of challenges to it. So kind of writing a law that reflects knowledge at a moment in time means that as that knowledge evolves, the law is not also going to evolve. But on the other hand, a downside to California's approach here is that, you can see that the old law prosecuted only unprotected sexual activity, and now it's conduct that poses substantial risk. And so that means that something like needle sharing could not have been prosecuted under the old law, but could potentially be prosecuted under the new law. So as you can see, there's no right answer, there's no good answer, and it's often between a rock and a hard place situation. Before 2019, Michigan criminalized sexual penetration, which had a very specific definition that included oral sex or any intrusion, however slight, of any part of a person's body or of any object into the anal or genital openings of another person. This language could clearly apply to a lot of things that we know definitely do not carry risk of transmission. The new law criminalizes anal and vaginal intercourse. While this is an improvement over, for example, inserting an object into someone's body, it still does not reference transmission risk. So condom use, for example, might not protect somebody here. Michigan's law is static. It's not dynamic like the California law that incorporates scientific standards and, which of course change over time and allows the law to change along with it. States may also limit criminalization to very specific situations. The most protective laws require proof that the defendant intended to transmit HIV to someone else. The most protective laws also require that the exposure actually resulted in transmission of HIV. But there are still plenty of states where someone can be prosecuted just for exposing someone, even if there was no transmission. In other words, someone can be prosecuted even if the alleged victim is HIV negative. As for defenses, these vary significantly as well. States may allow for a defense if the defendant disclosed their status or took practical means to prevent transmission, like using a condom. Viral suppression and adherence to treatment may also be a defense. But there are challenges to be considered here too. It's the defendant's burden to prove that these defenses apply. And you can imagine how hard it could be to prove that a condom was used or that disclosure occurred, even especially when you consider that most criminal defendants hold identities that are frequently discriminated against, and it's their word against a sympathetic alleged victim who claims otherwise. And of course, only someone who actually has consistent access to affordable care and treatment would be able to raise a defense based on viral suppression and treatment adherence. Nevada, I'm not going to talk about this too much here, but just to highlight a couple of states that have more recent reforms. Nevada is an example of a state that recently made some of the changes that we just talked about. And Illinois recently repealed its HIV criminal law entirely. I won't spend too much time on this today, but there are actually some good arguments to be made that even full repeal can have some unintended adverse outcomes. Basically, it comes down to this. If prosecutors want to pursue these cases, they will find a way to do it, and eliminating these laws just forces them to get more creative, which establishes dangerous legal precedent. So that kind of highlights that education, educating government agencies, educating, prosecutors, like education of all the stakeholders and all of the parties that are involved in this process is also really important. And just changing what the law says does not do away with the problem. Again, I'm not stating an opinion here that some laws are better than others. I think they're all bad, and that is NASTAD's position as well. I'm just emphasizing here that there's no good answer and certainly no right answer to the question of how to make HIV criminalization, quote, better. There is momentum right now to revisit and reform these laws and to instead focus on leveraging the public health system rather than the criminal system to end the HIV epidemic. The HIV National Strategic Plan recognizes that these laws undermine public health efforts to reduce transmission of HIV and calls on state legislatures to reconsider laws that act as barriers to public health goals. So of course, as we are NASTAD, a lot of our education that we do around this is targeted towards health departments. But what if you're not a legislator? What if you're not a health department decision maker? Is there anything that you can do to make changes to the laws in your state? Yes. So lobbying legislators and presenting the public health argument, talking to them about current knowledge and supportable scientific standards about HIV prevention, transmission, and care, highlighting the role of stigma in your work with people living with HIV, talking about how the strategic plan calls upon states to decriminalize HIV, and highlighting proven evidence-based public health interventions that are much more effective alternatives. If the goal really is to end HIV, throwing people in prison or making people afraid that they'll go to prison if they get tested is not going to get you there. And in a lot of states, health departments might not be able to initiate meetings with legislators, but advocates and providers can initiate those meetings potentially, and then legislators can request to meet with health department staff to talk more about the issue. And in this case, the health department, is not necessarily lobbying. Anyone can request a phone call or a meeting with their state legislators. You can do it too. And you don't have to do it alone. Across the country, providers, advocates, and health departments have formed coalitions working together to educate legislators and change the laws. Anything that can bring media attention to the harms of HIV criminalization, or even just educate news reporters on the issue, can also help move the needle. Did your local news write a story about a criminal case that included incorrect, sensationalized information about HIV? Maybe they'd be willing to speak with you about your experience providing healthcare or other services to clients in the community. Maybe they'd be willing to speak with you about how this type of reporting promotes stigma. Maybe they'd be willing to attend a community educational event about HIV. And don't forget that there are other efforts outside of lobbying or community-based coalition work that you can participate in, such as professional associations that have taken up this work. So NASTAD recently published a resource that includes information about everything we've talked about today, including how to get involved in grassroots efforts. I think these slides will be circulated, and so folks will be able to access this. Just in case when I'm finished presenting, I'll put a link into the chat for this, and I'll also add another resource that we didn't yet include in this document, but that I also think is very helpful. Right, so I know that was a lot of information. I'm here for questions. I don't know if questions are now or later, Rodderick, but whenever questions are happening for this session, I will be here and ready to take them. So
thank you, Dori. For the sake of time, we can do questions later. We want to make sure that Adrian has time to present. So thank you so much for that wonderful presentation. All right, Adrian, so this is all you now.
Great, thank you. I can share my screen, right?
Yes.
All right. Okay.
And we can see you.
Great. Thank you. And thanks for the opportunity to share a bit about our HIV criminalization efforts here at the New York City Department of Health and Mental Hygiene. My name is Adrian Guzman. I'm the Director of Policy and External Affairs for the Health Department's Bureau of Hepatitis, HIV, and STIs. So I'll just briefly talk about our Bureau, mostly to highlight the fact that we do have a policy and external affairs program that's been leading this work, which I think is unique to other health departments. Then I will talk about some trainings on HIV criminalization that we've led and some upcoming funded projects on HIV and criminal justice. And then just to emphasize the support for HIV criminalization efforts that are found within not only our local HIV jurisdictional plan, but the National HIV/AIDS Strategy. So as I mentioned, I am representing the Health Department's Bureau of Hepatitis, HIV, and STIs. We are at about 430 staff, and we're organized around 6 programs. And you can see that one of those programs is our Policy and External Affairs program. And I mention that, as I said, because I think we're unique in having the staffing and resources to really advance a lot of our policy advocacy when it comes to HIV and STI and hepatitis. So we oversee all of the local, state, and federal HIV, STI, and hepatitis related legislative and regulatory efforts. We monitor policies, funding streams, and health systems activities, and represent the Bureau in various policy work groups and coalitions. And of course, our external affairs team handles media, public relations, and communications. So I'm very proud to share all of this work, and just want to mention that it's also, we're able to do what we are because we do have a number of brilliant policy minds working on these matters within our Bureau. Speaking of which, some of the work that we have undertaken in recent years includes, back in 2020, the CDC Capacity Building Assistance Team requested that we lead a training module on legal and policy issues related to HIV cluster and outbreak response plans for health departments. So in that module, we covered, similar to the previous presentation, a brief history of HIV activism and an overview of HIV criminalization, and then the legal implications of molecular HIV surveillance, of cluster outbreak and detection response. And then closed with some health department best practices for ensuring that both local and state health departments are engaging in this work only after completing a really comprehensive assessment of the legal and regulatory landscape in their own states when it comes to these issues. Last June, we were excited to join the Association of Prosecuting Attorneys and the Center for HIV Law and Policy for the New York City's Prosecutors Roundtable on Criminal Justice Response to HIV and Infectious Disease. And we sort of provided the public health and clinical perspective when it comes to causes and transmission of bloodborne and airborne disease, and our own surveillance data and resources on HIV, hepatitis C, tuberculosis, and COVID-19 here in the city. And really that helped us mobilize and energize around this work. And so we were excited to, a year later, join the White House Office of National AIDS Policy, and again, the APA and CHLP for the White House convening on HIV criminalization. Many of you may have heard of the convening, but it brought together around 50 state and district attorneys, health department representatives, and White House and CDC officials to address HIV-specific criminal and civil laws and sentence enhancements that target people with HIV on the basis of their status. So our role, as we saw it, was to really emphasize the public health implications of HIV criminalization. As described in the previous presentation, this is just bad public health policy, disincentivizes testing and cooperation with partner services and any sort of healthcare engagement when it comes to HIV and sexual health. And we also wanted to emphasize the importance of health departments stepping up to lead these sort of partnerships so that we can bring into the room prosecutors, defense attorneys, and policymakers to address HIV criminalization in a sort of multi-pronged strategy. And an important component of that is to build HIV and sexual health literacy among criminal justice stakeholders. And then over the last couple of years, we've also been doing ad hoc presentations on HIV criminalization. So we delivered them not only to our own staff to raise awareness of the legal framework within which we're working in New York State, but also to external stakeholders. And as mentioned, these presentations are sort of similar to the previous one. They start with a definition or definitions of HIV criminalization. We feature select states' HIV-specific criminal laws and sentencing schemes. We highlight a couple cases involving arrests and prosecutions under HIV-specific criminal laws. And then again, really drive home the point that there are public health harms associated with HIV criminalization, and also emphasizing the role of local and state health departments in this work. So lastly, I just wanted to mention some work we have on the horizon. I mentioned that we participated in that Prosecutors Roundtable last June, and it in large part based on feedback from the prosecutors during that roundtable, we began exploring programming to address that intersection of HIV and criminal justice, both here in the city and across New York State. So we are in the process of funding an organization using CDC 1802 dollars to have them carry out 2 projects. These are temporary names. We're still working out the details, but the first is our HIV Criminal Justice Stakeholders Project, and the second is our HIV Criminalization Project. So for that first one, this one really focuses on stakeholders. We wanna identify all of the stakeholders that are involved in this area. So we are planning to fund an organization to develop informational products like palm cards and fact sheets tailored to a diverse array of criminal justice stakeholders. So we're talking NYPD frontline officers, prosecutors, defense attorneys, and possibly even the judiciary. And the subject of these materials would be the HIV 101, the basics of HIV and other infectious disease transmission, and also select state laws and regs and policies regarding HIV and infectious disease discrimination and confidentiality. So this goes back to what I just mentioned and what the previous presentation mentioned, that sexual health literacy is really core to this work. And so this is the first step toward that. And in addition to these products, these materials, we're also going to fund the organization to develop and implement literacy programs for these stakeholders, trainings, both in person and virtual, and hopefully work with some of these stakeholder organizations to build into their existing training content related to HIV and infectious disease. So that's the first one. The second one is our HIV criminalization project. And this one involves a whole array, a whole portfolio of HIV criminalization policy projects and programming. For example, the funded organization will conduct a local and state legislative, regulatory, and policy scan, analyze all of these policies, and then set forth recommendations for improving any of them which may be outdated or stigmatizing. And then should we move forward with those updates, the organization would provide us with technical assistance to update those policies, as well as our own internal agency policies to ensure that we are protecting staff and to ensure appropriate privacy protections for people with HIV or other infectious diseases. And one thing I have been trying to do since approximately 2015, when I joined the health department, is to launch an agency webpage that brings together all of our local and state laws and regs and policies related to HIV, a sort of repository of all of the different authoritative laws and policies. And since we recently merged with our colleagues focused on STI and hepatitis, we want to highlight those laws and policies too. And we're in talks with our colleagues who work in our Bureau of Alcohol and Drug Use Prevention, Care, and Treatment to see if we can also include on the webpage laws and policies related to harm reduction, including syringe possession and decriminalization and other related topics. And the whole point is to inform New Yorkers of the services, the level of the quality of care and confidentiality protections to which they're entitled under city law and under state law. And also, it's going to be provider facing. We want to make sure that we put providers on notice of the service delivery and reporting and confidentiality requirements they have under city and state law. And I sort of am envisioning the webpage as a companion to our webpage by our New York State Department of Health colleagues. They launched a New York State Ending the HIV Epidemic Dashboard policy tracker, which is part of our Ending the Epidemic Dashboard, which tracks progress toward ending the epidemic by various metrics. But there's a policy tracker, and this is designed to share our progress on various policy efforts that address ending the epidemic goals here in the state. So it's organized around our jurisdictional plan pillars and key activities, but we want to make this more public and provider friendly. So we want someone who is a minor and is unsure whether they can get an HIV test without involving their parent. We want them to be able to come to our webpage and get that information easily and quickly so that they can make their own choices around their sexual health care needs. So fingers crossed that will happen. We are having public health emergency after public health emergency. So in New York City, obviously, and across the US. So we're really hoping we can catch our breaths after our MPV activations and really tackle some of these projects to return to our core HIV work. Oh, and the last thing I want to mention, I won't go over this, but for all of you from health departments who may be anticipating or experiencing challenges advancing this work, I just wanted to remind you that there is support for some of this work in some of our jurisdictional plans. So if you are an EHE jurisdiction and you produced a jurisdictional plan, you may have included some content around stigma and discrimination. We did. One of our key activities focuses on working to end stigma and discrimination related to HIV status or marginalized identities. And perhaps more pointedly, the National HIV/AIDS Strategy for 2022 to 2026 does include very sharp language on HIV-specific criminal laws. It explicitly states that these laws don't reflect our current understanding of HIV and should be repealed or updated. So this may be the support you need to convince health department and state government leadership that this is a worthwhile endeavor and is critical to our broader ending the epidemic efforts. And that's all I have.
Thank you, Adrian, and thank you for all the work that you and your team is doing in New York. We really appreciate it.
Sure.
All right, so now I'm going to open up the floor for the Q&A session. So if you have any questions for Dori or Adrian, feel free to put them in the chat or unmute your device and go ahead and engage with us in the conversation and ask your question.
Hey, Rodderick, this is Maddie. I'm going to go ahead and ask a question that has been left in the chat about educating prosecutors and others in the criminal legal system. I think this could have a lot of benefits, but at the same time, there is a concern that drawing attention to the issue could lead to increased prosecutions, especially in areas where prosecutors' offices are politicizing their anti-poverty, anti-homeless stance. Like if this topic wasn't on their radar previously, but they learn about it and decide to start prosecuting. Does anyone have any experience or thoughts about this?
Well, I can say, it's not lost on me that I live in New York City and we're operating within New York City, which is a very different political and legal climate than most places across the US. So I think that my recommendation would be is to work with NASTAD and the Center for HIV Law and Policy and Association for Prosecuting Attorneys, who can help you develop a strategy on how to approach all of these criminal justice stakeholders, a strategy that would resonate with your own environment, your own landscape, because I think it's a really valid point that drawing attention may inadvertently convince criminal justice stakeholders to focus on this issue and to expand their enforcement of certain laws that otherwise would have remained obsolete. But I think there's always going to be an ally somewhere, and that's these national organizations that are doing this work can really help you identify those allies and frame your request, your ask, your information dissemination in a way that will resonate with those prosecutors and government officials.
Hi, this is Dori. I would agree. And I think this, it highlights the importance of like coalition work. This is a strategy question. And this is, you want like a unified message coming from the folks in your community who are doing this work. And so this, it's another example of why like coalition work is really important here. It brings a lot of different perspectives that any one stakeholder might not like consider, and kind of puts those perspectives together based on what's going on in that specific community and the legal climate in that community, and presents like a unified kind of case and strategy for what to do here. And like I said, this whole area is just like rife with unintended consequences. Like even a change in a law that sounds on one hand like, oh, this might reduce some harms, but then there might be other harms that could be created. This whole, because what we're talking about here is like inherently bad policy, there's always like unintended consequences that could come from different things, and having as many heads together as possible that are interested in this and want to make change is really important.
Thank you, and thank you for that question, Claire. Any other questions for our presenters? Okay. Feel free to put any questions in the comments. Unmute your device. It's an intimate crowd today. It's not a lot of us in here. Join the discussion. If you have anything you want to add, you want to comment, you have any questions, let us know. Alrighty. So thank you, Adrian. Thank you, Dori, for your presentations today. I think we're going to go ahead and wrap up. We're just shortly, a couple of minutes short from 4 o'clock. I am going to share my screen just to kind of show what we have coming up with the Social Determinants of Health. And we will go from there. All right, so these slides will be available. Sorry, y'all. The slides will be available, and we will send out the recordings at the end of this. I did include some resources at the end of the slide deck, and then also Dori has some resources that she put in the comment section and as well as in her slides. We had our comments and questions in terms of upcoming from the Social Determinants of Health legal series. We have our housing webinar on November the 16th at 2 o'clock. And then going into the new year, I haven't set a date yet for this, but going into the new year, we will start off with talking about youth and adolescents. And thank you for being here with us today. Have a good evening.
Thank you.